Hello, hi, and good evening, everyone. Welcome to the upcoming webinar from the Sports Medicine Training Program. We're very excited to meet you all. We're going to give you all a couple of minutes just to work your way into the webinar. For those of you who want to play along whilst we're doing this webinar, why don't you head across to the Sports Medicine Training website, click on the free stuff section, and you'll be able to play along with the slides that we've got today. And we've got a really exciting packed show here with us today. We're really excited to have a special guest, and you're going to hear all about him a bit later. But whilst we're waiting, why don't you drop your name and also where you're joining us from in the webinar? We love hearing from all of our audience and all our readers across the series. And today's the third webinar of the year. So why don't you drop us a message, tell us where you're logging in from, and we'll get going in a minute or so. Once again, if you wanna join along as we do this webinar, head across to the Sports Medicine Training website, click the free stuff section here, and you'll be able to register to access the course slides as well as some of the other free content that's available. So we'll get going in a minute's time. Get ready, and we're looking forward to meeting you all in a second. Okay, right. So we're good to go. Imran, can you see me okay? And Colin, are you here okay? Good. All right, so
Yeah.
let's kick off the webinar. Lovely to meet you all. My name is Dr. Irfan Ahmed, and I'm an MSK physician based in the UK in London. We're excited today to deliver the Sports Medicine Shoulder MDT, a really innovative way where we're going to discuss sports medicine imaging, MRI, ultrasound, and clinical decision making in the clinic. And we've got a nice teaching session, and we'll go through a simulated case from our upcoming course. First of all, I want to say a massive thank you to all of you who've joined us here. We've had registrations from all continents across the world, and thanks for making us the number one most read series on the British Journal of Sports Medicine website last year. Our blog on meniscus injuries is available on the pre-course reading and also on the website as well. So we're excited to announce our next course, which is a combined training course that brings together all the best bits of the series: MRI, ultrasound, and clinical decision making all in one space. We've had over 126,000 reads across the series, and we always love meeting you all live and in person. So today, during the webinar, you're going to meet my colleagues and the rest of the cast as well. So whilst we're waiting, we've had a record number of registrations this time round. 52% of you are from the UK, and that means the other 48% of you are joining us from all around the world. North America, the Middle East, and Europe, a number of delegates. So say hello in the comments and tell us where you're joining us from, and hopefully tell us what your favorite blog is, or perhaps what topic you'd like us to cover next. So look, uh, the sports medicine space and MSK medicine is ever-changing landscape, and it's sometimes difficult to keep up. I mean, you can go on YouTube, LinkedIn, various online courses, introduction to ultrasound, PG certificates, mentorship, MRI training, MRI tutorials. Just so much knowledge out there, and often you're stuck between going to a conference, trying to get together your handouts and understand how to put it all together. It can often be quite difficult because there's loads of different places to go, and actually sometimes what you want is courses that are designed to be in one place. So we've designed a course which is there for you to have all of the key bits of sports medicine all in one place, including the workup, imaging training, including ultrasound and MRI, and also evidence updates and treatments. And now for the first time, you can access it all online in one space together. So, we're excited to develop this partnership with the Advanced MSK Ultrasound Center that has over 70 hours of online content specifically for sports medicine and MSK clinicians who are working in this space. So, if you often feel overwhelmed, then access this content and material online on demand at your own pace. And it's a really nice way to learn. And we'll be going through one of the cases from the upcoming course here today. So I'm going to introduce the cast for today. So my name's Dr. Irfan Ahmed, and I'm an MSK physician based here in the UK. We're joined as ever by our attending MSK radiologist, somebody who needs no introduction, Dr. Imran Lasker, who's based here in London, UK. He's a veteran of Radiopedia and also of the MSK Playbook series, and also delivers the easy to understand MRI tutorials aimed at sports medicine clinicians who want to understand how to make better use of MRI scans in clinic, read the scan with your patient, and understand how to add value. And our special guest all the way from the States, Mr. Colin Rigney, who's a board certified orthopedist and a real heavyweight in the ultrasound and MSK ultrasound industry. Colin will be telling us a bit more about how we can really use MSK ultrasound in practice and how you can use the best tips to put that in practice in your care when assessing patients in clinic. So, look, it's difficult. You're managing complex cases. We're working between clinics. We're working between a sports medicine physician, a radiologist, a physical therapist. And actually, it can be really, really difficult and complicating. But actually, from my experience, the best learning place is the MDT. The MDT, where you get to discuss complex cases, learn to manage complex MSK caseloads, and really get on top of how to understand how to work up the patient is the place to be. So today we've brought to you an MSK MDT. So I'm going to hand over to my colleague, Dr. Lasker. He's the author of the MSK tutorials, and he's going to give us a nice little case that I've introduced him to. So without any further ado, Imran, I'm going to hand over to you, okay?
So hi everyone, my name is Dr. Lasker. I'm the consultant radiologist. Hopefully you can see my screen. Could I just get someone to just confirm that you guys can see the scan on my screen? Irfan, can you see it? Yeah. Okay, cool. So what we're going to do is we're going to have a bit of a discussion about this particular case. I think that this can happen quite often. You've got someone coming in and they've come in with a scan and you're thinking, okay, I don't even know where to begin the scan, but it says lots of fancy words and you're not entirely sure where to go. So I'm going to break it down. I'm going to go from very basics of how to look at an MRI scan, what we're looking on this MRI scan, and maybe some of you guys maybe to pick up the pathology before I even get to it. So what I'll do for to begin with, we'll just go full screen on this. I am going to scroll through this particular scan, and then if you see something great, if you don't worry, I'm going to go through it. So first off, we're just going to scroll through and scroll through and scroll through. And we're going through every single plane. You'll see that one plane moves and the other planes stay the same, but you can see where we are on the images. Just keep scrolling, keep scrolling, keep scrolling, keep scrolling, keep scrolling, like so. Okay, so I know at first it feels like there's a lot going on. You're not entirely sure what anatomy we're looking at, but this is exactly what we're here for, exactly what this course is about, trying to interact with each other and make sure that we do the best for our patients. So first off, to begin with, we are looking at an MRI scan, or in fact, we're looking at the MRI scan of the right shoulder. So I don't really have much of a history as far as I'm aware, but we just know that they probably had some pain or something like that. That's usually what it is, right? And so we've got your coronal images, which is where you're facing the patient straight on. Your axial images up here, over here, where you're looking from the patient from above. And this is the sagittal view or the side view. We're looking from the side. So now we've got all those kind of planes together. We can scroll through and try and identify specific parts of the anatomy. So as we come from the top, we're coming from the top now. We're kind of coming up to the point of the acromioclavicular joint. You can see there's a little bit of this kind of bright stuff over there, which we'll talk a little bit about later. We're coming to the next bit, and there's a little dot over here is a really good landmark for when you're looking at any bicep. I mean, when you're looking at any shoulders on MRI scan or ultrasound, that's the biceps tendon. Scrolling down, scrolling down, scrolling down. That's it. Now we're going to go to the next view, and that's going to be looking straight on at the person, and we're kind of walking through this person's body. And now what we can see is a humeral head that's sitting over here. We can see the glenohumeral joint where everything attaches. We're going to see the AC joint all over again. And also we can see the sort of this stuff over here and this stuff over here, and that's your muscles. And so what you can see here is that the muscles and tendons are now being seen in a slightly different point of view. Now, I'm going to use this opportunity as we look at sort of the person front on, because we all kind of know what people look like from front on rather from upside down and the rest of it. I want to try and identify certain bits of anatomy or certain things that this MRI scan is showing. So this MRI scan, it kind of shows you something very specific, right? And it may not be obvious at first, but what you'll notice that the subcutaneous fat, which is underneath your skin, doesn't matter how much you work out, you're always going to have a bit of fat underneath your skin. Looks a bit dark. It looks a bit dark, right? And then you can see certain areas that look a bit bright. So generally speaking, when you're looking at MRI scans, depending on what view you're looking at, this kind of makes certain parts of the anatomy look brighter than others. And in this particular image that we've got, the fat is very, very dark. Therefore, that means that we've, for whatever reason, darkened down the fat signal on purpose. We don't want to see the fat. We're not interested in the fat. We're interested about everything else. Therefore, that means that anything that's bright in this particular image is going to be fluid. So now we've got to go back to another concept. Let's think about the things that we know to be 100% true when we're looking at any person. So we know that the bones exist, right? So when you look at the bones, that must be the bone. It looks anatomically like a bone. It looks like the humerus. It looks very, very dark. So why does it look dark? It's because it's made up of fat. And like I said before, the images on this particular sequence are made to look dark. But what you'll also notice, I've got this very dark black outline, right, all the way around like so, all the way around like so. So there are certain areas here that are very, very black. So if you're not entirely sure what that is, think back to your anatomy. What is at the surface of every bone? It's cortex, right? Cortex is at the surface. So cortex doesn't have very big blood supply, not particularly fatty, very, very calcified. Therefore, anything that's black on this particular image is going to be cortex. But other things that are avascular are also going to have a very black appearance. So tendons, by definition, don't have very good blood supply, don't really have much going on unless there's something wrong. They're also going to look very, very black. And if it doesn't look black, then that's something that you should be worried about. So we're going to scroll through and we kind of got ourselves kind of the idea about what certain signals look like. Dark versus light, bright versus dark, all that kind of stuff right now. Now, the other thing about anatomy of the body is that things usually connect to something else. They kind of continue into something else. Very rarely you'll have something that turns up and disappears in a couple of slices. And what you'll notice about here is that you've got your bone kind of ridge that's sitting there, which must be the scapula, suprascapular notch that's sitting over there. And then this can be the infrascapular area over here. So over here, you've got what looks like muscle. And the muscle kind of goes along, 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 and then thins out and then becomes a tendon. And if we kind of scroll through again, you can see that, yeah, this is a muscle that's gone along and becomes a musculotendinous junction and then carries on and then it becomes this kind of thinner structure. Now, I've been speaking a lot about the abnormal signals versus normal signals and the rest of it. And I told you already that the things that are going to be very, very dark are going to be avascular material. But this should be very, very dark because this is going to be a tendon. But in this particular image, it doesn't look like that. So that doesn't look like a normal tendon. It looks like it's got a bit of brightness in it. And we also know that whatever's bright on this image is not going to be fat. It's going to be fluid. So therefore, there must be fluid located within those tendon areas located within that supraspinatus area. What can be causing that? It's going to be a long-term injury. It's going to be tendinosis. It's going to be overuse. It's going to be all sorts of things that can cause it. So at this point, we can say that there is definitely something up with that supraspinatus that doesn't look normal. Now, the other thing that we may have also noticed when we're looking from the up from the all the way down is that a acromioclavicular junction, it looks a bit, it should be flat, like bones should kind of come like this and then go straight onto each other. But this has got that sort of irregular contour. It doesn't look quite correct. It looks like there's an abnormal contour to it. Therefore, this must be indicative of something going on. This must be something like osteoarthritis. And the osteoarthritis is defined by a few different things, especially on MRI scan. You're going to get subarticular bone marrow edema. So if we look at that, yeah, it does look a bit bright around the articular surface and around the bone. So that must be the subarticular bone marrow edema. We've also got this sort of little kind of indentations, outpouchings from there. That must be osteophytosis, which is another thing that can be a sign of osteoarthritis. And we could also say there's a bit of loss of joint space. So there's a few things here that are going on that makes you think there's osteoarthritis. But why am I laboring this point? Is because when you get a bit of osteophytosis going underneath like so, it means that this muscle can't really slide along like it should. And if it can't slide along, that results in something known as impingement, which is actually better seen on an ultrasound scan, but can also be inferred when you're looking at an MRI scan. So we've seen a few things so far. The other thing I wanted to point out is that biceps tendon that we are looking at earlier. Similar thing, biceps tendon should be very, very black, but it's not very black. It looks kind of slightly odd color, looks a bit different as you kind of come down, come down, come down like this. Sometimes you get something called a magic angle, which just means that when you take the image at a specific angle, it looks a bit bright. But this one feels like it goes on for a little bit too long, and therefore you've got to be concerned there could be a certain level of inflammation located in that area as well. Right. Is there any more on this scan? Has anyone noticed? No one said anything so far. So let's keep going. So when you look at the axillary recess, this is the bit of kind of your joint capsule that goes all the way around your glenohumeral joint. And sometimes that can look a little bit thicker and there can be a little bit of fluid. I think it's going to be difficult to really call. I mean, there could be a little bit of fluid around there, but it'd be a soft call. I wouldn't say 100% obvious, but there could be a little bit of fluid around that glenohumeral joint, which would therefore mean there's inflammation. And if there's inflammation, this must mean there's inflammation of the glenohumeral joint, which is otherwise known as adhesive capsulitis. But there was one big thing on here, right? There was one really big thing. And I'm going to scroll through and try and show you on this particular image over here. So now what we're looking at is the patient from the side. We're kind of looking at them from the side and hoping they don't look back. And what you'll notice is that when you've got the humeral head sitting like this, it kind of, to me, looks like a face, right? I haven't drawn a great face, but it looks like a head, and they're looking straight at you. And so what you'll notice is that these tendons make it look like they've got hair. They've got hair there, they've got a bit of hair there, and a bit of hair there, and actually corresponds to the subscapularis, infraspinatus, supraspinatus, and yes, you do have a bit of bicep tendon there. Why is this interesting? Is because actually, when you think about it, tendons are not just tiny little threads. They're like sheets, like bed sheets that go along like so. So what can happen is that you can have a partial thickness tear where only some of it's gone. You can have full thickness tears where all of it's gone. You can get bursal surface tears or articular surface tears. And when you're going on the side view, what you can have is that they look like a bald person. They've got no hair there, but they've got sideburns. Or sometimes one sideburn is there, but nothing else is there, and therefore you can infer that there are full thickness tears of certain tendons. But when we go scroll through this, we were talking a lot about how things taper into one another. And what you can see here is that you got this sort of thin tendon going along here, but there is something that's kind of a bit of a blob that pops up there, and maybe another blob that pops up there. And that doesn't seem right because they kind of come in and go, and they don't seem to go into any tendon, they don't go into any muscle, they don't go into any bones. And we think, okay, where did that come from? Let's go back to the previous views and have a look and see if we can find them anywhere else. So we're here again, we're looking at the patient for straight on, and let's see if we can find those blobs anywhere else, anywhere else. And there you go. Can you see that? There are some blobs that are sitting right over here. One, two, three, four. There's about four blobs sitting there. Okay, so we've seen it on two views now. So there is something kind of different about this person. We've seen the sagittal views. Let's see if we can see it from the top. Let's scroll through. Let's go back to from the top to the bottom and try and see if we can find the similar area that we saw earlier. And I think we just jumped, so we can't see it there. But we definitely see it on at least two views. So yeah, exactly right. Someone said it. It looks like there's calcific tendinopathy located within the infraspinatus tendon. Now, interesting case because you don't normally get it there. You normally get it in the supraspinatus tendon. But we've got a few things going on, right? We've seen that there is a bit of tendinosis located in the supraspinatus tendon. We saw that there was acromioclavicular junction osteoarthritis with some osteophytosis, which is resulting in some narrowing, i.e., impingement. We saw that there was a little bit of fluid and a slight abnormal signal of the biceps tendon, which makes you wonder whether they've got a bit of slight tendinosis. There's a little bit of fluid around the glenohumeral joint, which also suggests they've got adhesive capsulitis. Maybe very, very mild, but it's probably there too. So we've seen on this one scan quite a few things, and we've also been able to relate it to key anatomy that's useful for anyone that's looking after patients. So, Irfan, I think there are a few questions that you may have had for this person. Did you have any questions you wanted to ask?
Yeah, no, that's fantastic, Imran. So we have some questions. Sorry, I should have been a bit more descriptive in the in the handover, but I'll just bring the slides
Hmm.
back in. Okay, so this was the clinical history, and this is quite typical of a clinical history you probably read, Imran, right? Shoulder pain,
Hmm.
6 months, restricted range of motion, query rotator cuff
I
related
can't see
shoulder.
your screen. Are you sharing your screen? I can see
Uh,
you, but I can't see your slides.
Let me just if you make me host again,
Okay, let's do that.
or if you share the presentation, you'll be able to do it that way.
Okay, I'll do that. Let me just show. Am I sharing my screen?
Yeah, if you share it from your screen.
Okay, let's do that. So you can see that, and let's go to This one, slide. Okay, can you see it?
Yeah, so perfect. So I didn't
Yeah.
give you too much information, but that's usually what happens on a referral form. And as you probably identified,
Hmm.
if you don't give much information, you're not going to get much back in the way of sensible diagnosis. So look, we've got a few questions here from the MDT, and a great way to learn is, when people start with MRI, often there's a hesitancy to get into MRI because it's really hard to get teaching. You might not know what's going on. You don't want to overcall stuff on a scan. So I've got a few questions for you. Do you mind just clicking through to the next one?
Hmm.
So you've given me about 5 or 6 diagnoses there. At some point, we're going to have
Hmm.
to explain this scan to the patient. There's a couple of things that often come on an MRI. I've got a quick question. Do you mind going to the next slide? Um, it often comes back with clinical correlation advised. But the
Hmm.
question is, if you go to the next one. What's the best way, particularly when you're learning, for trying to assess for rotator cuff tears? And bearing in mind, people often get tears, tendinopathy. Is it a tear? Is it not a tear? What's the best view? And what's your tip for anybody who's learning in the sports medicine clinic, learning to understand how to interpret MRIs of the shoulder?
So what I'll do, I'll just quickly go back to the case, and this is what I was talking about a little bit earlier with regards to looking at it from the side. Now, one of the things that people make the mistake is that they think that they're just tiny threads of rope that go along, but the idea that these are actually not tiny threads of rope, they are in fact sheets, and they actually feel like they're almost continuous with one another. Sometimes you get a bit of a tear of a supraspinatus as well as a bit of a tear of the infraspinatus. You can get a bit of both. But what I would say is that have a look at it from the side view and imagine the face. If you imagine the face that I draw earlier, and also draw that hair out. So you've got sideburn, and then you've got that sort of top bit of hair there. And just make sure that that kind of always seems like a sheet all the way along. As you scroll through and as you get used to it, you'll start to notice that little bits may be missing. It looks a bit thinner in some areas and then others, like maybe someone's got the clippers and not gone all the way across. You'll notice little bits there that don't look quite right. But for me anyway, I find this particular view the most useful view to find the rotator cuff tendons and really assess them.
Great. Imran, we've actually got a question from the audience.
Hmm.
So if you go
Yeah,
back
I
to the
think we have
scan,
someone raised their hand. Should I let them talk?
yeah, go
Yeah,
for it.
go for it.
Hello, Ayman. Are you there?
Hi, man, you're just on mute at the moment. Okay, whilst we're waiting for Ayman,
Oh, so someone has said that is there a tear of the
yeah,
superior labrum on that particular scan? Oops, I've gone out of this one. Let's have a look. So ideally, you do want to have a arthrogram study if you're looking for labral tears. And so you can say there could be a little bit of, see that sort of fluid level located over here around the origin of the biceps tendon. And that tendon does look a bit abnormal. Do you remember when I was saying it looks a bit abnormal, a bit further up around here, but I wasn't 100% sure because we could be getting an angle. But now we see it on two views, you've got to be concerned that there could be something going on with that biceps tendon as well. So it's going to be tendinopathic, and there may be an underlying slap tear or a slight kind of pull of that tendon as it emerges into that superior glenoid. So that is a good spot and correct. Thank you. Was there any other questions?
perfect. Yeah, so I've got another question for you as well, Imran.
Hmm.
Um, what are the common pitfalls when trying to report on rotator cuff tears? Now, you mentioned a little about magic angle. Do you mind
Hmm.
telling us a little bit about that? Because it can often be a pitfall and people start to overcall things on a scan. Do you mind just explaining that?
Yeah, so this is one of the learning points from this particular scan is that when you're looking at that biceps tendon, at first it looks like that there are some bright areas if we go on the actual views looking from the top. But the thing is that it doesn't always correlate with underlying pathology. And the way to do that is by first off having a look at that biceps tendon. If it looks slightly abnormal on this particular view, try and remember where you are and then look at it on another view. Because there's an angle at which when something's turning and the images are taken, it looks bright anyway. And that actually happens in ultrasound as well. And it's called magic angle there as well. So just something important to be aware of when you're looking at any sort of tendon and you see some sort of brightness, do have a look at another view and do have a good look and see whether it's also bright on the other view that you've got as well. And then, yeah.
Great. That's a great learning point. And I know as you do the MRI tutorials of the lower limb on day two of the course, it's a really nice bit as t tendons take a twist and a turn around the knees and ankles and so on. Good. I like that imagery. I like that idea of the haircut. And you can access these slides online from the Sports Medicine training website. Are there any other questions from any of the panelists or any of the other members of the attendees? We've got about a minute before we hand over to our guest speaker. I've got actually an introduction for Colin.
Oh, someone has asked something. Someone has something. What is the specificity of MRI in detecting fractures, including occult ones? So very good actually, because remember I was telling you about fluid being bright and everything else being dark. So if you've got a fracture, by definition, you're probably going to have some edema. And so sometimes very subtle fractures can come up really, really bright. And so MRIs can be very good for looking for stress fractures, which can be very small, hard to see on an X-ray. It can be very good for looking for contusions, where are kind of like bone bruises, and bone bruises can be really quite bad. And X-rays have got a lot of overlap between the different anatomy. So with an MRI scan, you'd be able to identify where the problem could be because of the edema. And also the T1 signal images are very good for looking for the actual fracture line. So you said, what is the specificity? I don't know the exact specificity, but I know that they can be very, very good. Like as in, if you haven't seen a fracture on an X-ray and the patient is still acting like they've got a fracture, you've got to do an MRI scan because you can pick up really, really subtle ones. Cool. So I'm going to hand over now. Thank you.
Okay, all right. So we've had some questions about how to access the slides. So if you go to the Sports Medicine training website and you click on free stuff, you can get access to a bunch of these materials, including some of our previous lectures, as well as some free infographics as well. If you want to learn more about frozen shoulder, rotator cuff tears, some of the evidence for specificity and sensitivity of those studies, you can always head across to the website and click on the full article where you get access to that. Right. So if we've got no further questions, what I'm going to do, I'm quite excited to hand over to our guest today. So we have Mr. Colin Rigney, who's joining us from the States. Colin Rigney is a physical therapist with board certifications in orthopedics and musculoskeletal ultrasonography. Colin is the CEO and co-founder of the Advanced Musculoskeletal Ultrasound Center and also works out of Phoenix, Arizona. He also serves as an adjunct professor at A.T. Still University in the physical therapy department where he instructs radiology and imaging. He really is a unique insight and somebody who I have recently come across, and it's great to collaborate with him. And I'm going to hand over to Colin if you'd like to share your screen.
Thank you, Irfan. And thank you for that warm introduction. And everybody, welcome here from the United States. I'm based in the Phoenix area in Arizona. So what I'm going to do, I'm going to get into it. Okay. So let me share my screen and we're going to, let me know if you can see that. Irfan, thumbs up.
Thumbs up. I can see that.
Okay, great. So let's go. Let me go back here. So we're on slide 20. Okay, so I'm going to take you guys through, before we could talk about like a whole lot of normal or abnormal, we want to know what normal is, okay? And it's beyond the scope of this talk here to do a full deep dive, but let's just get a bird's eye view of what that is, okay? So what normal is. The image on your left, you see a long axis image of the supraspinatus. Okay, so unlike MRI, ultrasound, we're looking at two views. It's called long axis and short axis. So the image on the left here would correlate with like a coronal MRI scan, except it's way blown up. Okay, so we're seeing the fine details of the cortical surface of the bone, the fibrillar patterns of the tendon, the fascial layers of the bursa, and of course the overlying deltoid muscle in the skin. Okay, and on the right side, we see what's called a short axis image. So it's a corresponding image just turned in the opposite direction. So we're looking at it transversely. Okay, this image right here would be on the right would be more analogous to that of a sagittal image on an MRI. And so if you can see my cursor, this is the bicep tendon here. So this lets me know that's medial. And then over here to the left is lateral. This is supraspinatus. And then to the right of the biceps, this would be where the subscapularis is. And in between this tissue, we have, this is called the rotator cuff interval. So we have a mix of ligaments of the glenohumeral joint and the coracohumeral joint, the biceps pulley, things that hold the interarticular portion of the biceps nice and stable through there. So let's go through an advance here. All right, so calcific tendinopathy. Okay, let's walk through what this looks like. This can take a whole spectrum of appearances on ultrasound. Okay, so the one you're looking at here, this is a long axis image of the supraspinatus tendon. And you see my cursor, this outline here, we call this a hyperechoic foci or hyperechoic focus. This is casting a shadow. This is an artifact called posterior acoustic shadowing. So we know it's pretty dense. Okay, so this is one view. We see it's covering up a good portion of the tendon. Okay, it looks like the tendon is overall intact because we have a fair amount of volume here, meaning the distance from the bone to the bursal layer is maintained. We just have this piece of calcium in here that's like a rope over a rock. It's kind of fraying away at that tendon. You can kind of see it the way it's arching through. So whenever somebody moves their arm away from their body, this is creating a shear effect in here, causing a perpetual cycle of inflammation. So unlike Dr. Lasker, right, who is oftentimes doing this without a lot of clinical history on the back end of it, we're doing ultrasound at the point of care as an extension of our clinical brains. Okay, so a good physical exam history and a protocol sequence through the shoulder is going to lead us to ruling in and ruling out what's on our cluster findings from the exam. Okay, so ultrasound is not a replacement for any other image modality or your physical exam. It's another tool to use. Okay, oftentimes you still may need an MRI because we can't see the intra-articular structures quite the same way. All right, however, when we're looking at a lot of extra-articular pathology, ultrasound is a very nice tool to do so at a very high resolution. Okay, so this is what we're looking at here, this calcific tendinosis, as we go through. So how do we know tears, calcifications? How do we differentiate what's what? I'm going to use this term. There's a term called pathognomonic. When you see over on the left here, this is another long axis image of the supraspinatus. Okay, you see this calcium. This is a different patient now, but a similar appearance. Okay, when you see this calcification in the tendon, you have to assume there's a level of tearing, and it's more like fraying. So I tell patients when we have this finding, the tendon is grossly intact. Okay, but there's no way that there's not a level of fraying going on secondary to that calcium. So I tell people, like when you have an old pair of pants or jeans or shirt that's kind of fraying at the seams a little bit, that's kind of what goes on with this finding, right? And then this slide in the middle, this is just displays the spectrum of what you can see in one particular scan, and you have to do a number of these with good guidance and some feedback to know the difference. So, you have a small calcium deposit at the footprint of this tendon. These dark patchy areas, these are signs of focal tears. Really, they're microscopic tears in line more of a tendinosis. But so when we're using our words carefully with patients to define things, okay? Again, focal tears. So you can kind of see it's not out of the ordinary to find multiple things in one image or one particular case. Okay, and it's up to you, the clinician, to decide using the tools available, what's the road you're going to go down when it comes to treatment. Okay, now this patient on the left here, we let's assume that there's no other intra-articular issues, possibly there might be some incidental findings of AC joint arthropathy and that sort of stuff that Dr. Lasker talked about earlier. But I'm throwing this picture now on the right to okay, when you see really big, what we call anechoic spots, okay, that you're seeing right in the middle here, that's a tear. All right. Now, and the spectrum of how you define these, again, is beyond the scope of what the goal is today. But I wanted to display these to you as a means of just giving a solid overview of what the presentation may entail when you put the probe on somebody, because sometimes you don't know. And even when you to do a uninvolved extremity comparison, sometimes you'll find that, hey, they might have something here and they're just asymptomatic, right? And so now it's up to you to help them. And then again, it gives you an education time to talk to them about, okay, maybe your other side has some similar findings. Let's come up with a game plan to make your symptomatic side feel more like your other side, right? And so it's also a tool. It's a trust accelerator. Ultrasound is to build rapport with patients. Okay, but the spectrum of how tears and calcifications show up can be large, and the more you use ultrasound, the more you'll get more comfortable at explaining how to differentiate each and how to best educate the patient with your findings. So here is an example of an articular surface tear. Okay, this is a long axis image. You're looking at a bird's beak here. So this is this cortical irregularity you see at the greater tuberosity. This is a chronic avulsion of the tendon away from the anatomic footprint, where you see the arrow pointing to the dark patch, right? So that's in my estimation, a high grade articular surface tear. So we talked about the calcific tendinopathy and some treatment approaches. A lot of my role, what I do professionally, is I work as a consultant with a number of physicians in my city and who are in our education program, our residency program. And we teach guided techniques with ultrasound, what to do with the findings, right? And so what we're seeing here is one particular injection approach. Okay, we encourage you to be able to do multiple approaches. So this is a barbotage technique. Okay, this is the approach we take to do a barbotage or a fenestration, or however you want to, whatever your intent is. Okay, you should have multiple ways to do it. I'm showing you one particular. Okay, so you see the patient on the left, the way that they're positioned, that arm and extension, and the needle trajectory. This is a short axis image, and the needle trajectory coming in from lateral to medial in plane. You see the reverberation from the needle going into the calcium. This particular slide is a PRP injection. We did a barbotage weeks before, and then we're going to fill it with platelet-rich plasma. Okay, so this is a lot of this is good discussion for perhaps at the end of this or another time, with how do you deal with the findings, right? But I wanted to show everybody one particular way, one particular approach we deal with these things. Okay. Doing ultrasound for the past 16 years, I've run the spectrum from student to teacher to now mentor and a larger educator. And some common pitfalls. So if you're new to ultrasound or you're on the early side of starting your journey, I do think it's important that resources and guidance are a large part of what drives your learning. Okay. So some common pitfalls that I just shared here. Unclear if there has to be clear learning objectives. So if learning objectives are unclear, the weekend course mentality, the piecemeal education, it's going to leave you adrift, and you're not going to have clear competency milestones. You can't treat mentorship and feedback as optional or piecemeal ad hoc. Your training, your skill development has to be consistent. So if any of you have played a sport, I played basketball in college, and I know when I was playing at my best as a ball handler, if I didn't touch a ball for a couple of weeks or even a month, my skills were rusty for the first week coming back. Okay. And ultrasound is very much a motor skill with your hand-eye coordination. On the early stage of learning, the mid stage of learning, repetitions are required to stay very consistent. There's a phrase that Simone Biles, the American gymnast, uses with her training, and I think this applies to medicine and specifically image, learning how to read images. Is you don't train so you get it right. You train so hard so you can't get it wrong. Okay, and once you reach a certain threshold in your training, then you're at the point where the rustiness doesn't come on as easy if you take some gas off the pedal. Okay, so defining your mentorship responsibilities, setting a good relationship with your teachers, your educators, and then one thing, the soft skill development, the communication. I mentioned this earlier. How you educate the patient, what to do with the findings, is as big or bigger than your ability to actually diagnose something. Okay, especially at the point of care level. Do they need an MRI? Do they need a referral to a specialist? What's your treatment recommendation? How are you going to explain those things? Okay, and doing it at the point of care with ultrasound gives you that opportunity because they've already bought into your authority, your trust, because you can do this confidently at the bedside. Then it's just an easy lead into the next conversation if you develop this over time. Okay. Irfan, how are you doing?
Yeah, we're good. We've got a couple more minutes, and then we're going to do the clinical decision-making bit of the lecture.
Okay, great. So this video is about 4 minutes. So let me go ahead and play this. Okay. And this is an example of how we do a supraspinatus exam that I've done for the university.
Spinatus. Now, the supraspinatus, like I mentioned earlier, the best way to see it is we have to put them into extension. Okay, so we're going to put this patient in what's called the crass position, or in this view, actually, nope, flip around the other way, the semi-crass position. So you put your hand on your hip, and I'm having you scoot forward in your chair so you're not touching the back. Good. And then put this elbow into a little bit of extension. So we're really putting the shoulder in extension, exposing the tendon from underneath the acromion. All right. Now, in this view, we're going to start long axis. So we're going to look. So how do I know it's supraspinatus? Well, I know where the biceps is. Okay. And we know that the supraspinatus is lateral and posterior to the bicep. We're seeing bicep fibers here. I'm going to move slightly lateral to it. And the first structure you move into, this bird's beak, is the supraspinatus. Okay, so I'm going to go over a couple important landmarks. Okay, the footprint of the tendon is about 12 to 16 millimeters. Okay, so if I'm correct, if I'm in that range, the articular surface of the humerus starts to drop off right here and it forms the ball and it moves into the humeral shaft off to the left. Okay, the footprint is from here to here. So I'm about right. It's 11 or 1.14 centimeters, 11 and a half millimeters. Okay, so we ballpark that just about right. And then from here down is your articular margin. So just so you understand bony landmarks, you understand the anatomy. We're not just anatomy generalists. You have to be able to master these positions. Okay, so keeping our patient in this position here. Again, let's find that view. See how this hooks in? This is this hump right here. This helps us separate kind of the footprint of the insertion versus the articular margin of the humerus. And our tendon is basically from here to here. Okay, subacromial peribursal fat layer is basically from here to here, and then over the top is our deltoid muscle subcutaneous layer on the very top. Okay, now some nice things you can do with the ultrasound that separates it from other imaging modalities is the dynamic aspect. I got you. Let me just take your elbow. Okay, so what we're looking, I'm just wagging this patient's elbow through kind of an assisted range of motion into extension. Okay, what am I doing in extension? Well, I'm stressing the footprint of the rotator cuff. Okay, if there's oftentimes with big retracted tears, what you see when you put the patient into extension, you see some tendon retraction. You see the tendon move one way, the bone move the other. As you see what we call this paradox of movement between the two, the tendon bone relationship. Okay, but in a healthy shoulder, you'll see them both move at the same rate, which is what we see here. Okay, so whatever you look in one view, you look in another. So I'm going to turn it into short axis in this view, and I'm going to come up on what we call the rotator cuff interval.
Okay, so I'm going to pause it there, you guys. This video you have access to as part of the slides. I want to leave some time for discussion amongst the panelists and any questions you all have for all of us. I really appreciate everybody and your making the time to be here tonight, and specifically, myself included as a guest. This is a tremendous day and opportunity to share with you all. So with that, I'm gonna unshare my screen and pass it over and be available for any discussion I'd love to have.
Okay, great. Thank you so much for that demonstration, Colin. As you can see, look, any imaging modality only gets you so far, and it's actually really good to be able to cross those boundaries between MRI and ultrasound and discuss cases live. If rotator cuff tears and tendinopathy has got you interested and you want to learn more, you can always click on the blog online. So you go to the Sports Medicine Training website, you click on the link, and it'll take you directly to the article all about rotator cuff tears. As you know, we've got a number of other articles, and there's something in there for everyone, whether it's bone stress injuries, whether it's looking after patients with meniscus injuries, spinal insufficiency fractures. All of the blogs and articles come with these infographics to help you understand how best to work up patients. Now, speaking about how best to work up patients, we've got this patient with multiple pathologies here, and now we're going to have a little bit of a discussion about what the next step is. So I'm going to head back over to our PowerPoint. All right, can you see everything okay, Colin and Imran?
Yeah, can see it.
All right. Okay, so look, we've got calcific tendinopathy, and as Colin said, like the scanning and the doing the imaging and interpreting the images is one part of the consultation. Often the most tricky or challenging is explaining those to the patient in a way that they understand and going through the different options available to you in front of you. If you're interested in calcific tendinopathy, we have a module on calcific tendinopathy on the online course, and we go through the 5 or 6 key factors to ask about when trying to work up calcific tendinopathy. First of all, understanding what stage of the calcification it's at, really what quality of life or impact it's having on them, what it looks like on imaging. And we do imaging, and we do draw numbers, and we take measurements. Is it a small calcific deposit? Is it a medium-sized one, or is it a large deposit? And if you were to take that deposit out, what defect, as Colin mentioned, what defect does that leave in the tendon? And do you have to potentially do something about that? The longer I'm in the MSK business, I think that metabolic history is so important, and more and more we see if patients are more convinced that we're dealing with MSK presentations often of metabolic history, so understanding about those risk factors in patients who've got metabolic syndrome, perimenopausal, or in their middle years, perhaps they're in that spectrum of fraying or degenerate tears. So if you want to learn more about that, then check out the module online. If you found this really interesting, then we've got 46 MRI cases that are scrollable with 20 evidence update lectures that summarizes the key evidence about these conditions, alongside 7 MRI tutorials, and now access with Colin to ultrasound training videos, all combined in one space. We'll be talking about a bit later. Now you've got a scan in front of you. We've got calcific tendinopathy. We've got a suspected slap tear. We've got a bit of frozen shoulder or adhesive capsulitis. Where on earth do we go with this scan? Because the report sounds like there's a whole lot going on. For those of you who are joining us in clinic or who join us on the course, we talk about the skim technique. And really, this is the way I go through any scan with any patient. I'll have a look at the scan and I'll go through it in this order. Start with your symptoms. Before you do a scan, you've got to have a plan. So, why do we even do the scan in the first place? Often it's missing from the clinical information, and you might even be reviewing somebody that somebody else has seen, one of your colleagues has seen, and you've been asked to go through the report with them. So really honing in on the key symptoms and why that happened. What are the key imaging findings? What do you think is the driver? Thinking about those incidental or age-related findings, like how common is it to have a partial thickness tear of a rotator cuff in that patient age group or that patient demographic, and then going on to the management. So this is one of the studies that we come across in the frozen shoulder module. So I think it's quite clear that this patient has a few pathologies going on. It looks like from the clinical history, although brief, that the restriction was the main problem with the patient. And we really need to understand how we can unfreeze that shoulder and get them going. Now, often when we think about patients, we think about steroid dosing and we think about, do no harm, treat the patient, improve their range of motion. But we want to think about perhaps doing a steroid injection or those procedures under ultrasound guidance. This is an interesting paper from 2023 that gives us a bit of food for thought about the kind of dosing that you might think about in hydrodistension. This is a study of 84 patients published by the Wang et al. Group, and it was double blind and randomized, which is good. They used an injectate or a total volume of 20 mils into the glenohumeral joint. And really interestingly, they use these two different treatment groups, either 10 milligrams of triamcinolone or 40 milligrams, which is normally a normal full vial. Now, looking at those doses, 10 milligrams, that looks like really like a pediatric dose. It's a very low dose in comparison to most injections, and 40 milligrams might be considered a standard dose. So, what did they find in these patients in this double-blind randomized study? What they found is that ultrasound guided hydrodilatation with either 40 milligrams or 10 milligrams of triamcinolone yielded similar improvements in SPADI, VAS score, and range of motion at 12 weeks of follow-up in these patients with frozen shoulder. Albeit this is relatively short-term follow-up, but actually that's quite interesting. 40 and 10, if it's giving you the same short-term outcome, and if you're thinking about a patient that might be at risk of having underlying tears, do you really want to expose the tear to that much of the steroid? Is there a route to go at a lower dose? And perhaps even if you needed to repeat it, you've got some room or some headroom for maneuver. So consider this when you're thinking about steroid dosing, particularly in those patients where you're unsure or uncertain, or there's a suggestion of an underlying rotator cuff tear alongside the frozen shoulder. And think about those negative impacts potentially on cartilage, tendon, and also systemic side effects. So, really interesting study, and it really makes you think about, what's the dose and what's the optimal dose. This is another study that looked at a systematic review in frozen shoulder dosing. And they found that, look, when they compared range of motion and pain scores, they found four studies that met the inclusion criteria, and that 40 milligrams provided as much relief or improvement as 20 milligrams, so half a dose of the steroid, provided as much benefit as a full vial. And that really does give you food for thought when thinking about your steroid dosing and how you're going to plan a procedure, particularly if you've got a patient who's got those metabolic risk factors. Perhaps they're diabetic, perhaps they've got bilateral symptoms, perhaps they've got other things going on in their medical history. And maybe if it's a chronic frozen shoulder and you're thinking this is at risk of perhaps I might need to go in and do a repeat procedure, actually giving yourself the headroom by using a lower dose of steroid can be quite useful. So we've got a patient essentially has got a frozen shoulder, plus minus a few other bits and pieces that are really impacting their function. So if you enjoyed the MDT today, this was an interesting case of a frozen shoulder with other pathology going on. Imran's got an interesting proposition for you, and I'm going to hand over to Imran, because sometimes you're thinking, you know what, I like learning MRI, I like learning ultrasound, but actually I need to learn it together. And I'm going to hand over to Imran, who's going to take over.
So yeah, I mean, this is why I think this whole thing is so unique because I've been to radiology courses, which is run by radiologists, but sometimes you need everyone to work together. And a lot of the time when we learn, especially as clinicians and people looking after patients, it's a multidisciplinary approach that is missing. And that's why I think we built this, and this is why it's going well, is because people find this kind of style of learning where you get a person who's got someone physically there who's trying to treat the person, answer those questions, with someone like myself who is also trying to treat the patient, but by looking at the images, and you have someone else who's actually trying to rehabilitate that patient once we've identified what the problem is. So we often get asked, what kind of services do we offer from sports medicine training and the Radiology Seminars crew? We deliver comprehensive MRI and ultrasound course training, and especially aimed towards people who are interested in sports imaging. It's just a quick image from a recent course that we ran. These are comprehensive CPD courses that we run for people. We've done ultrasound, we go through MRI, we go through the actual sports medicine side of things, or what to do with when you've got someone who's been injured on the field. And this can be done in person and on demand. And via the package, you can get access to all of these things. This is a very wordy slide. Please don't worry, I don't expect everyone to read it. What we're just saying here is that the bigger picture is that we're trying to make a bigger difference to as many people as possible, because ultimately we're trying to help people, we're trying to help patients. So we help by doing these courses, we can improve the staff development, we can elevate everyone's clinical excellence so that we all work together to actually work towards patient care and client care and athletes experience to be better. And also for ourselves, we've got to get CPD points as well. So through us, we're able to give that to you guys. So we've got a really comprehensive course. We put everyone together. We put all our work together to create both an on-demand upper limb course and on-demand lower limb course. You can see how comprehensive it is. It really does show you. And Colin's actually shown us a sample video of some of what he's got, and his material is brilliant. So he's gone through how to actually examine each part of the body. So that's the theory. That's what you can watch. And if you actually wanted to come and see us face to face and learn from us face to face, we do also have that. So what we're going to do is, if you want, you can go to our website, Sports Medicine Training, and you'll find the link to Colin's website. Then you can use the discount code SMT20, and that will give you a discount. Now, obviously, we do sell to individuals. If someone wants to learn themselves, then by all means, come to our courses. But we actually find that it's far better if we work with institutes. So, but working with groups of physiotherapists, groups of sports medics who want to work together, entire institutes of sports medical training facilities who also want to work together. What we can do is actually cater the offer to work for the number of people that are coming to us. So let's say you get to a point where you get 600 or 300 people, we can offer a 60% discount, because it means that we can try and accommodate for more. We know what's coming in, and we can actually do a really good job for everyone involved. So the thing is, we do offer flexible payment terms as well, and there's also the chance to do annual bulk purchase as well. So we really do work with you guys, and what I'd encourage you guys to do is, if you are interested, please either check out our website, check out Colin's website, or just use a scan code, scan this, and just book in a consultation with us. We have a chat to you, what we could offer you, the place you work, the hospital you work at, the institute that you work with, or maybe a group of you that want to work together to try and better your skills and get better, elevate your skills and help your patients. So appreciate you guys. Thank you so much for coming. I hope you guys have learned something. I probably should just show you the website quickly. So this is our website. When you get there, you can come onto the mailing list if you want to know what's coming up later on, or you can click on the Advanced MSK Ultrasound Center. That will take you through to Colin's group, and there you'll be able to find the courses that he has and use that discount code, which will be available for you. So yeah, if there are any questions, please let us know. I think there were a few questions, and I think we have managed to answer them in the chat. So if there are any other questions, please let us know. Otherwise, I hope everyone's had a good evening. So I'm going to hang around for a bit and see if anything comes in. There've been a few questions about injections. Has anyone seen that? My understanding is that with pretty much most of the high volume injection targets in MSK care, for example, knees as well, most studies suggest that no difference between 20 milligrams, 40 milligrams with either. Oh yeah, okay. Yeah, I mean, look, from a radiologist's point of view, yeah, I do understand that. And actually, I remember someone telling me that there's some paper about if you do an injection in somewhere else completely, it can still have an effect on the person. I mean, this is going to be a risk to a benefit ratio, and I personally would start low, and then you think about increasing the dosages if it's not working. But that's just my personal preference. And also, it very much depends on the clinician. As a radiologist, it depends on what the clinicians want. Sometimes orthopods want a specific dose. They want a specific type of steroid to be used because that's been their experience to be useful, and you just go ahead and do what they ask actually. Irfan, your experience?
Yeah, I think it's a really good question. I think it goes back to I guess what the underlying driver in the diagnosis is. I said the longer we do this, we're seeing the stronger links between metabolic health and the actual underlying condition. There's some interesting studies and papers that come out about frozen shoulder and the metabolic component there, and understanding what stage of the frozen shoulder they're at and what you're trying to achieve. So I guess with the hydrodistension, you're trying to get a bit of volume in there. So you're trying to physically distend the capsule, and that factor will happen regardless of the steroid dosing, and then you want to have an anti-inflammatory type effect. And it is true to say, yeah, a lower dose at 20 milligrams is seen to have an equal effect as 40 milligrams. I think about those patients, you might think, you know what, I'll do one hydro distension. I'll see how they go. I think they're more of a stage 2 or 3 frozen shoulder, and we might need to repeat this again in a few months' time. Actually, by dropping the dose, you give yourself that headroom. I think it's a really nice conversation to have as part of your MDT, particularly when you're getting referrals into the clinic and be able to offer that advice. If you want to learn more about obviously the frozen shoulder, then you can check out the full article online. But that's a really good question, and it definitely gives you food for thought. Colin, any thoughts on that as a
No, this is a great discussion. We, you know, the doctors I work with in our circle has become more biased towards orthobiologics for most treatments now, with a few exceptions. Calcific tendinopathy barbitages are one of those where we use steroid because it works quite well, and the needle technique I was describing earlier is how we get there. But you know, the hydrodistension is a great way to address frozen shoulder, and I do think the stage they're at matters, and how you use that, and whether you decide to use it or not over a manipulation under anesthesia, and the metabolic health side of it, the holistic side of how they got to that place, is of course a major player in the diagnosis. But I just enjoy being a part of this, you guys, and you know, I hope it's been a value add.
Yeah, I'm sure it has. It's been brilliant. Thank you so much. So I can't see any other questions so far. So yeah, I guess we'll just finish out by saying, yeah, check out the website, add yourselves to the mailing lists. Do get involved if you can. We would love to meet you guys if you want to talk about having group bookings and work with your institution. That'd be absolutely wonderful. And at the very least, if you come and spent your time with us and given us your time, hopefully giving you something back by learning a few things and having a few thoughts to think about how to treat the next person that you see. So yeah, I think I'll say goodbye from my side. Irfan, thank you so much. Colin, thank you so much, and thank you everyone that attended. I think we had a really big turnout, so I really appreciate it. There was one question. Do we offer courses for sports medical trainees? Yeah, I mean, I'll quickly answer that. Yeah, our course and Colin's course is going to be useful for sports medicine trainees. There will be certain parts of your course that will have some image interpretation. Some aspects will be more appropriate for Irfan, where we'll talk about the actual management. It does cater quite nicely to all of it, actually. Colin is located in the United States. I'm located in the UK, and Irfan is also located in the UK as well. That was one of the questions. Cool. All right then. Thank you, everyone. Bye.
Okay, thank you.